In this session, we are diving deep into diabetic retinopathy grading, a key concept in ophthalmology that determines how we screen, follow, and treat patients with diabetes. We begin with the earliest stage, mild non-proliferative diabetic retinopathy, or NPDR. The only visible change here is microaneurysms, tiny saccular outpouchings that form when parasites, which normally support the capillary wall, are lost due to hyperglycemia. This is an early marker of capillary wall breakdown. It might seem subtle, but microaneurysms can leak fluid, initiating the cascade of macular thickening. Catching this early is vital because there are still no visual symptoms, but the disease process has begun. Next is moderate NPDR. In this stage, you'll find microaneurysms along with dot and blot hemorrhages, hard exudates, and sometimes cotton wool spots. These lesions represent worsening vascular compromise. Cotton wool spots indicate localized nerve fiber infarcts. Hemorrhages signify deeper retinal bleeding, and exudates are deposits from leaking lipids and proteins. At this stage, the retinal tissue is clearly struggling. Perfusion is compromised, but neovascularization hasn't begun yet. It's a critical window where intervention and tighter systemic control can still make a difference. As the disease progresses, we reach severe NPDR, defined by the well-known 4-to-1 rule. That's hemorrhages or microaneurysms in all four quadrants, venous beading in two quadrants, or intraretinal microvascular abnormalities, IRMA, in one quadrant. These findings signal widespread retinal ischemia. The retina, being highly metabolically active, starts producing VEGF in response to hypoxia. That VEGF is what triggers the next and most dangerous stage. Severe NPDR means the patient is teetering on the edge, with up to 50% risk of progressing to proliferative changes within a year. We now reach proliferative diabetic retinopathy, or PDR. This is where neovascularization appears, either on the optic disc, NVD, or elsewhere in the retina, NVE. These new vessels are abnormal and extremely fragile. They grow along the surface of the retina and into the vitreous, where they are prone to rupture, causing vitreous hemorrhage. Fibrous proliferation around these vessels leads to tractional retinal detachment. If they grow on the iris and in the angle, they can cause neovascular glaucoma, a blinding and painful complication. This stage is considered vision-threatening. The goal here is to rapidly reduce VEGF levels with panretinal photocoagulation or anti-VEGF injections to halt neovascular progression. Let's not forget diabetic macular edema, or DME, which can occur at any stage of retinopathy. DME is the leading cause of visual impairment in diabetic patients. It occurs due to breakdown of the blood-retinal barrier, resulting in leakage of fluid into the macula, the area responsible for sharp central vision. We classify it as focal, leakage from specific microaneurysms, diffuse, widespread leakage from dilated capillaries, or CSME. Clinically significant macular edema, defined by the ETDRS as retinal thickening within 500 microns of the foveal center, exudates within 500 microns with adjacent thickening, or retinal thickening, all one disc area in size, located within one disc diameter of the fovea. DME demands urgent attention. It's not just a structural problem. It affects visual acuity directly. OCT is used to assess severity and guide treatment, which usually involves anti-VEGF therapy, and in some cases, focal laser. To summarize, grading of diabetic retinopathy includes mild NPDR, microaneurysms, only moderate PDR, more extensive hemorrhages, exudates, and ischemia, severe NPDR. 4-2-1 rule, high VEGF state, PDR, neovascularization, vitreous hemorrhage, traction, DME. Fluid at macula can be present at any stage and causes central vision loss. Understanding each stage helps not just in staging the disease, but also in predicting prognosis and planning management. From systemic control to laser and anti-VEGF therapies, the key is early identification and timely intervention. If you enjoyed this walkthrough of DR grading, hit like, subscribe, and comment below on which retinal condition we should break down next. Stay sharp, stay focused, and keep learning with ophthalmic sticky notes.